Hello everyone, my name is Amanda Williams and today I am presenting case 51 from 100 case studies in pathophysiology, Addison's disease. This is for Nursing 711 at Liberty University. I'll start with the patient's story, then briefly define the disorder and epidemiology, then we'll walk through the pathophysiology at the cellular level, and link that back to specific signs and symptoms our patient is seeing and why that matters in her disorder. Then I'll close with the Christian worldview in the APRN role, and then we'll focus on 3 study questions I've chosen from the Breyer's case study text. My sources today are the Breyer's case study, and then 2 articles I have selected and looked at from Medelsky and colleagues. It's a review on Addison's disease, and then Wolf and colleagues review on the autoimmune primary adrenal insufficiency, which we'll look at. Okay, let's get started. CK is a 48-year-old Caucasian female who presents with 4 months of progressive fatigue that has been worsening over that timeline. She describes that she's become markedly more weak over the past week. She is visiting her sister currently, has been here for 2 weeks, and has not been able to do normal activities like hiking or biking, which are usual activities that she can complete. Over the past 5 days, she also has developed a noticeable loss of appetite, mild nausea, and remarks about an unusual tan with minimal sun exposure. Before she developed the nausea, she was craving salt. She does report intermittent dizziness with 1 syncopal episode in the past 6 months, and then about a 6-pound weight loss in the past month. Denies any fever, chills, cough, or night sweats. She does have a past medical history with an appendectomy several years ago with surgical intervention. She also has a history of a positive PPD conversion 6 years ago, and that was treated with INH for 12 months. She does have ongoing pernicious anemia that is treated with monthly B12 injections, and then has diet-controlled hypercholesteremia. She does, we'll get more into this, but does have a notable family history of multiple thyroid disorders, autoimmune thyroid disorders, and her husband also has Addison's disease. Socially, she manages a small business for work. She does not use tobacco, she doesn't use illicit drugs, and drinks wine occasionally. All this is adapted from the case study in Breyer. Okay, getting into the disorder description and epidemiology. The description is Addison's disease is defined as primary adrenal insufficiency, most commonly caused by autoimmune disorders. It is an autoimmune destruction of the adrenal cortex, lowers cortisol, aldosterone, and androgen. In a clinical picture, the patient will present with chronic fatigue, salt craving, hypotension, and diffuse hyperpigmentation. All of those we see in our patient of CK. They also will have a low morning cortisol level in association with a significantly high corticotropin level. The treatment for Addison's disease is lifelong hormone replacement therapy, including from hydrocortisone or prednisone, and then adding on fluorocortisone in times of stress for the body. So, for example, in times like pre-surgery or sickness, anytime the body's under extra stress, it needs a little extra steroid since it's no longer producing cortisol. Epidemiology, it's a relatively rare disease, estimated that about 100 to 140 cases per million people in developed countries. The prevalence does seem to be on the rise, though. Once it was primarily thought to be caused by tuberculosis, now is most commonly caused by autoimmune disorders. Now, we do have the previous positive PPD for CK. However, this ongoing pernicious anemia seems to be at a greater risk for causing the Addison's disease that we're seeing in her. And then diagnostic abilities and materials are definitely progressing. All this came from the Metelsky and colleagues. Okay, pathophysiology at the cellular level. So it's autoimmune, usually in nature. Autoimmune adrenalitis progressively damages the hormone-producing cortex in the adrenal glands. Glucocorticoids are not produced due to the lower functioning in the adrenal glands. Antibodies show up at 21 hydroxylase. It's a hallmarker of Addison's disease if you're positive for that. And then T-cell mediated inflammation does drive up tissue loss as well and destroys the layers of the adrenal glands. So then we see as cortisol production falls, the body loses glucogenic drive. Cortisol, helps promote vascular tone. So we lose that vascular tone. Patients do feel fatigued, they have a low blood pressure, and they can become hypoglycemic as well. As aldosterone drops as well, the kidneys, they waste sodium, they retain potassium. Most of these patients will show up as hyponatremic or hyperkalemic, and then they will also have some volume depletion as well, showing up as orthostatic hypotension. Because cortisol is no longer providing negative feedback, it drives a marked rise in ACTH. And then finally explaining the hyperpigmentation, the POMC-derived melanocortins, they stimulate the melanocytes, basically, that they produce more melanin. That explains the hyperpigmentation that you'll see kind of diffuse. There will be in areas of friction and then in the creases of skin. So palmar creases, the elbow, bend of the elbow, back of the knee, and then around like a brassiere line or a pants line. All this information was gotten from Wolf and colleagues. Okay, so subjectively, in our case study discussion, our subjective data, just as a reminder, we kind of already covered some of this in the beginning, but CK, her chief complaint is 4 months of progressive fatigue and weakness, has become markedly worse over the past week. Additional symptoms of nausea, loss of appetite in the past 5 days, unusual tan, especially in the skin folds and around her bra lines. She did have a salt craving prior to her nausea development. She does deny any infectious symptoms. Given her history of pernicious anemia, which is already autoimmune, and a high family risk of autoimmune disorders, she does have 2 sisters with Hashimoto's and 1 sister with Graves' disease, as well as a mother with rheumatoid arthritis. Puts her at a high risk, or gives us a high suspicion for developing an autoimmune primary adrenal insufficiency. On our objective data, she is orthostatically hypotensive, 80/60 standing blood pressure, 95/79 sitting, or 75 sitting blood pressure, 110 standing heart rate, and then 83 sitting heart rate. Her general appearance is that she does have dry mucous membranes, generalized hand experience, sparse axillary hair, and +1 pedal pulses, so a little low there, showing some volume depletion. And then again, the increased skin pigment to the creases and the bra line. We also did some fasting morning labs. They show hyponatremia. Her sodium's 126, hyperkalemia, and potassium is 5.2. And I'm sorry, I don't know how to move my head out of the way, but her glucose was 55, so she was a little hypoglycemic as well. Did show some mild anemia, hemoglobin of 11.4, and most importantly, I would say markedly, her cortisol was 2.0. This is, again, these labs were drawn at 8:20, and a markedly elevated ACTH at 9:47. Again, we also did a UA, an abdominal CT, which showed adrenal atrophy. She also underwent a rapid ACTH stimulation test, and that's really the hallmark testing for Addison's disease or primary adrenal insufficiency, showing that her cortisol remained low, her ACTH remained extremely high. Given the subjective data and the objective data, all things in this clinical picture are pointing to adrenal insufficiency or Addison's disease. Okay, my favorite slide. So from the Christian worldview, care starts with showing God, I feel like, in our care for people. So I have picked some verses from the Bible that I think truly emulate these things that I also put on the slide. So first is care for the sick as a service to others. Our true role is to serve others, both in our Christian walk and in our nurse practitioner roles as well. So Matthew 25:36 was my inspiration for that. I was sick and you visited me. Moving on, including personal and spiritual needs to encompass the whole assessment. That just, to me, means that we should really take our role seriously, but also give the patients the tools that they need to support their spiritual needs as well as their personal needs. So include the family, include prayer, include whatever they may need. And again, my inspiration was that 1 Peter 3:15 specifically, be ready to always to give an answer to every man that asketh you a reason of the hope that is in you with meekness and fear. And then finally, providing a sense of community and support in bearing burdens with patients. Specifically with our patient here, CK, it's reasonable to think that she's probably scared, she doesn't feel well, she's away from home. While she is with her family, she's not in a place that's familiar to her. So bear ye another's burdens, and so fulfill the law of Christ. Galatians 6:2 inspired me for that. Okay, and finally, the case study questions I chose from our Breyer's case study book. What is the single greatest risk factor for Addison's disease in this patient? I would say that it's pernicious anemia. Given that is an autoimmune condition, puts her at a greater risk for developing other autoimmune conditions. Also, adding on her family history of autoimmune disorders would put her at another risk, but the single greatest risk factor I would say is pernicious anemia. Secondly, what is the most likely cause of Addison's disease in this patient? I would say autoimmune adrenalitis, because we said pernicious anemia is her single greatest risk factor. That's autoimmune in nature. Again, autoimmune is destructing the adrenal cortex there. And then the single test result diagnostic for Addison's disease, the gold standard is a rapid ACTH stimulation test. It confirms primary adrenal insufficiency. And finally, here are my references. That is all.